Well, it's a pleasure to be here, and thank you very much again for the opportunity to talk about a technology that I feel very strongly about and has been instrumental, I think, in helping to guide me and our surgical practice as we sort of tiptoe through the minefield that can be refractive surgery. These are some of the observations that I've come up with purely from a clinical standpoint in the last 3 years, over 7,000 cases. The first thing I want to talk about is how this concept can be embraced and is embraced by patients. And I think that corneal strength is something that is far more intuitive for patients to grasp and grab hold of than discussions of corneal shape, which are often lost on them. It doesn't require a lot of fancy colors. It doesn't require any knowledge of topographical maps, as do corneal shape discussions. And patients just get it. You know, a brick house versus a straw house, or a boat made of steel versus a boat made of balsa wood. You know, it's easy for patients to understand if you tell them they've got a strong cornea, or a cornea that has a corneal resistance factor that's in the 50th percentile or more. It's reassuring for them. And I think it's an opportunity to distinguish yourself from the competition, because when you have these discussions with patients, they're going to feel like you've gone the extra mile for them to ensure their safety. And, you know, in this day and age, patients are shopping around all the time in this economy, and I find that they will be back. And when they shop around, they're not going to find competitors that have this technology yet, because there's just not a lot of people using this excellent technology to help guide them. Your practice can appear much more cutting edge with screening tools like the Ocular Response Analysis. And I think it's important to make sure the patients understand that it's not just the old air puff that they used to get at the optometrist. And I think showing them really helps when you receive the data. You know, I've found that the Aura has saved me more patients than it's lost for me. And in the cases where I have lost a patient because the Ocular Response Analysis corneal resistance factor was too low, I was happy that I didn't do surgery on them. I think, and you know, we're inundated with irregular corneas these days that are coming from a myriad of reasons: contact lens abuse, you know, history of gas permeables or torics, trauma, you know, of course, RK patients, AK patients. You know, in the face of corneal irregularities, it's nice to have a little reassurance that patients, in fact, have strong corneal properties, tissue properties. You can save a lot of lamellar procedures, and when you're able to do that, because convenience-wise, patients really want to be out the door and back to work the next day. And although I'm an Air Force guy, and PRK was sort of the vast majority of what we did in the Air Force, PRK may not, and in my practice, it doesn't seem to refer or generate as many referrals as the lamellar procedures do as fast. You know, but it's nice to know that you can save a lot of patients who otherwise might be non-candidates, and provide them with PRK if you get good numbers here. Again, I'm happy to avoid those patients that have repeatably low CRFs in the setting of a high waveform score. Definitely feel like I dodged a bullet in those cases. You know, I think when you discuss, and it's a delicate discussion with patients when we talk about their non-candidacy, again, I feel like they grab hold of the concept of their cornea as being weak a little bit better than they do this idea of their cornea as being too irregular. And I think that if you're able to establish trust with these patients, they're going to refer their candidate friends and family, even if they're not candidates themselves. One observation I've certainly found is that you have to watch and respect dry eyes. Dry eye will wreak havoc with your waveform scores. It'll certainly improve with an improved ocular surface, as David discussed the concept of the reflectivity that is taking place, and the capturing of that reflected light. It's going to capture much more crisply, and a lot more light is going to be captured on a solid, smooth ocular surface. A port tear film will disperse that light. It's going to increase the chatter throughout the waveform. It's going to usually lower the overall scores that you see and the waveform score as well, in addition to CRF. I found that sometimes just a preservative-free artificial teardrop, either a low to medium viscosity, certainly not a high viscosity artificial teardrop like Celluvis, because this can certainly change and mask your hysteresis values. But a low viscosity artificial teardrop and waiting a few minutes can help you get a better quality test. And I think that if you're continually getting bad waveform scores, you got to look at what's going on. Is it a head position issue? Is your technician not properly trained on how to position the patient? Is the patient flinching in anticipation to the test? Are the patients, do they have dry eyes, or is it a calibration issue with the machine?